In this year, 2017, we have seen the first clinical outcome studies presented and published on PCSK9 inhibition, and we have now reassurance that this approach can actually safely reduce cardiovascular risk in our patients. The major aim of the revised version is to appreciate the clinical outcome data and also to identify patients we think are most likely to benefit most from this new treatment approach. I think it has been an agreement that it's very important that the patients are optimally pre-treated with the current possibilities, in particular intense statin therapy, and we have a more refined assessment of absolute cardiovascular risk in our patients, because it is clear to the task force that the absolute LDL reduction and the absolute risk of the patient are the major drivers for the benefit the patients can derive from this treatment. We have now 3 thresholds of LDL in this revised consensus paper. One is a primary prevention setting, familial hypercholesterolemia patients and LDL above 180. Then we have a threshold of 140 mg per deciliter that applies to patients with established atherosclerotic cardiovascular disease. And then we have a lower threshold of 100 mg per deciliter LDL cholesterol. And these are patients considered to be at particular high absolute risk. And this can be identified either by patients who progress rapidly with their clinical atherosclerotic cardiovascular disease, or patients who have indices of increased risk that can also be derived from imaging analysis, such as patients with very severe 3-vessel disease, left main disease, and so on. So this assessment of absolute risk has been one important new focus